non-malignant pain was undertreated and that opioids were the drug of choice. And so we as physicians, and particularly pain physicians, embarked on a journey to stamp out all non-malignant pain. And part of the way we did that was to apply the World Health Organization pain ladder to non-malignant pain. I believe personally that was the downfall of the whole thing. There was no data for any of this to occur. We have treated successfully many patients with chronic opioids for a number of years without significant dose increase, without them going to IV drug use. But even after this became the norm, there was no studies were done that were reasonable and that showed us what the potential problems would be and what the positive results would be. But as a result of that, obviously prescription drug availability in the general public was quite high. And so individuals who wanted to get those medications could find them in anyone's medicine chest. And at that, also in that same time frame, riding off of that wave, new longer acting opioids were introduced. And as a result of that, diversion, misuse, and abuse increased. And then ultimately, as heroin began to displace oxycodone, deaths started to climb. Next, go ahead. Their question? Okay, next, please. If you have any questions, jump in anytime. So this went on for quite some time. 2012 was sort of the beginning of the peak of IV drug overdose deaths. And so in 2016, the president, who was Obama at the time, ordered the CDC to come up with some guidelines for primary care physicians about the proper use. And this is a summary of those guidelines at that time. These came out in March of 2016. It's at this point that doctors started to become anxious and felt scrutinized, and those of us who thought we were doing the right things were tarred with the same brush as those individuals that ran the so-called pill mills. So in summary, and she will pass these out and send these out to you so that you can have them for reference. So this sort of started to lead to where we are today. So you try non-pharmacologic therapy if possible, you set goals, you make sure that risks and benefits are weighed. Immediate release and extended release opioids became a pariah, even though they can be useful. Use the lowest dose possible, and you set out a goal of how long you're going to treat and what you're going to do with respect to weaning, if anything. And then you're going to go over risks and benefits. Urine drug testing was recommended. Next, please. Their physicians obviously didn't really care much for the guidelines of 2016. And so there was a long period of time where the CDC was getting a lot of negative feedback. If you look at the 2016 guidelines and you delve deeply into them and you go to the backmost part of the report, there's a very interesting section that tells you, and they start out by saying, we were only given 6 months to do this task, and that wasn't enough time. And this is how we did it, and we did the best we could given the severe limitations we had. And so over time, then the initial CDC guidelines are where we got the daily morphine equivalent dose thrust upon us, even though that is somewhat arbitrary. So in the revision, they continue to push the dosage, daily dosage MME equivalent down and down and down. You are really now, and many states have laws that require to use some kind of opioid risk tool or some kind of risk evaluation prior to initiating opioid therapy. I'll tell you, and I think there's some information here later on, that anything that exists nowadays that's a simple, easily administered in your office, like the SOAP or the CALM or some of those other things, the opioid risk tool, are next to worthless, but they will protect you if you have at least shown that you've tried to do that and that's in your chart. And then it talks about stopping opioids. We're fortunate in West Virginia, when the last legislature passed laws guiding opioids, that they made it, there's no way that you can be affected if you, for good reason, decide you're going to terminate a patient that you've been giving opioids to, nor are you required under any way, in any way, shape, or form, to give someone opioids if they want them. Next, please. This is a summary as best I could do it for you to try to get it down to its least common denominator. So start low and go slow. Try to use non-opioid therapy when possible, and be careful. We're going to talk a little bit about universal precautions later, which I think is probably the best way to go at this moment. Next, please. This is what it looked like in 2015. These data are always a few years behind because it takes time to compile them. And this is the amount of MMEs prescribed per person per area. And you can see that Appalachia, and particularly the area of southwestern West Virginia, eastern Kentucky, and western Virginia, is in the darkest of the dark. Recently, you've heard stories about some small pharmacies. Tug Valley is the one that comes to mind, that were getting 3 million hydrocodone, oxycodone in a several month period in a town of 380 some people. And the distributor said, well, how are we to know that this was out of the ordinary? So let them defend that hill if they want to. Next, please. During that time, and as things went on, and the downward pressure, obviously, on physicians to prescribe less and less had a significant effect. And so you can see that over time, particularly after 2012, as I said before, that there has been a steady decline of total number of prescriptions and prescriptions per 100 persons throughout the United States. And so everyone's breathing a sigh of relief. Next. In Florida, where they initiated the most strict legislation, you can see that as prescriptions dive, as prescription numbers dived, prescription-related deaths dived. So kudos to everyone, correct? Next, please. Unfortunately, and continuing on to today, the overdose death rate continues to climb at the initial rate that it was climbing around 2012, and it continues to climb today, with some changes in the slope of the line to some very almost vertical at times, with the introduction of fentanyl into the market. So all of these external forces upon physicians prescribing have done nothing in relation to IV overdose deaths. That does not mean that we shouldn't have done this, but this is an illustration, in my opinion, of what happens when government tries to affect medical practice for some social good. Next. So this is, if you look at this and you see the synthetic opioids, they are on a steep climb, and the other opioids have sort of leveled off. Their slope of growth is not as steep. Heroin continues to grow at whatever rate it's growing. It's linear. It continues to be on the same slope. But then when other drugs like fentanyl came on the market, they were more highly sought after because their potency was significantly different. And if you look overall at any opioid, it matches basically the number of, it's very similar to the slope of the fentanyl line. Next. This is a handout that goes with the CDC guidelines. And so this is the way they look at things. I think when you see charts like this, it gives you a very good look inside the department and what they're trying to do. So very simply at the top, high prescribing. And the solution, less prescribing. So this is the departmental or agency look at the practice of medicine, completely discounts any social or economic factors that may weigh in as to why addiction's occurring. Next, please. These are all available at the CDC website. And if you don't have them in your office, I recommend you post them around to let patients know that you are trying to do your best, and also will drive off some individuals who may come into your office trying to seek medication for less than honorable reasons. This made the most sense to me. So back in the 80s when HIV was identified, we went to universal precautions for blood and body fluid. And because at the time you didn't know who was positive and who wasn't positive. And this is probably one of the greatest safety moves that we have done in medicine. And so there were articles written recently in the last certainly 5 years or maybe a little longer about using a universal precautions approach to opioid prescribing. So that is to say that you, without giving any particular negative value, you approach each patient that comes in your office as a potential misuser or diverter. And basically what it's saying is you apply the same rules to everyone. And so if you draw blood, you put on eye protection and gloves and all those things. So the same thing applies. Whatever you do for one of your opioid patients, you should do for all. This is common sense and probably will get you farther than anything else I tell you. Next. Time out a minute, I got to clear the screen. So these are two quick clinical cases that are actual cases that came into the clinic here within the last 6 months. So on the left, and as you all know, we've preached this to you ever since this has begun, that we're now an integrated pain center and that we are not just interventional, but we have really good practitioners like the two guys that are flanking me. We have all the services anyone could ever want to manage pain in what we now call a biopsychosocial model. So a young lady comes into my clinic. She's 49 years old. She has a BMI of 35. She has a severely degenerated left hip. She has a history of rheumatoid arthritis for which she's receiving treatment from a rheumatologist. She smokes, and her goal, which is a reasonable goal, is to be able to run around and play with her grandchildren. And so obviously, from my standpoint, the method here of treatment would be smoking cessation, control of the rheumatoid arthritis, exercise for weight loss purposes and for strength and flexibility, and a consultation with an orthopedic surgeon. And her response to me is, "Can't you just give me something?" And my answer to anyone at that point would be, "Ma'am, those days are gone. And this is a problem that you will have to address, and we'll help you address it if you want. But the way to do it is not to just give you a pill, but is to correct all the correctables and go from there." She did not accept that and moved on. The second person was an older lady with bad knees who just wanted to go to church and have lunch with her friends weekly, but it hurt so much to walk, and on the days she did activities, she couldn't sleep. And so she needed a pain pill on those days, 1 or 2 a week at most, to get to sleep. And so this is a perfectly reasonable person to consider for low-dose intermittent opioid therapy. And this woman, no matter how much we discussed this with her, was terrified that she would become addicted and be like any of those other addicts who are on the streets. And so we had a hard time convincing her. And even then, what you'll see, and I know all of you have seen this because you've talked about it, you may dispense 15 or 20 pills for her, and she'll bring 16 of them back for the next visit. And so it's a constant battle now to have any individual who might benefit from opioids even consider their use. Next, please. I'm in an email battle now with the Board of Pharmacy, and I want to hear from all of you. So have any of you gotten these emails that say, we just want to notify you that you have a patient who in the last 6 months has seen 7 physicians or more for medication? Anyone gotten that yet? Well, we get those because obviously we write a lot of opioids because we get everyone who no one else wants to take care of some of the time. So one of these patients that I get this flag on, which after discussing it by email with this young lady, she says, oh, we're just trying to help you. So you have a patient who has an intrathecal pump in for whom we prescribe no other medication, who gets lorazepam, Ativan, from a family doctor for anxiety and uses that once or twice a day as needed. And so that got flagged. So what they're doing are making decisions to warn you that you are outside guidelines without any clinical information and any ability to make a clinical decision. So I'm fighting this battle for all of us, and these are the kinds of wars I like and the kind I usually end up winning. And I pointed out another case we had of a gentleman with shoulder pain who's on multiple medications. And if you simply had the chart, you would know that he has metastatic lung cancer. And the reason he's on multiple medications at doses outside normal ranges is because he's terminally ill. And her response was, oh, that seems to be reasonable. Well, of course it's reasonable. And so just be aware that we here and through several committees that interact with the legislature are trying not to have us be constantly scrutinized. These are my recommendations based on the information that I know, my experience and training. When in doubt, use the PDMP. And in this discussion with the pharmacy board, the information they gave me is no different than what you would have had if you checked the PDMP regularly. Now, by law, you're only required to check that on the initiation of therapy and once a year. But it depends on the staff you have and how busy you are. I would recommend more frequently than less frequently. We do follow-ups every 30 days. By Senate Bill 273, you're only required to do it every 90 days, which means you can give a prescription with 2 follow-up prescriptions to be taken with them. I recommend highly a contract and a consent, urine drug screens at random, pill counts as often as you're comfortable doing it, and low tolerance for violations of contract. We've discussed this several times in this forum of the difficulties of decision making. And so I'll tell you that the easiest way is if you find a violation and you verify a violation, that should be sufficient to terminate the relationship. Now, I know that's black and white, and I know that many of you will disagree, and that's okay. But I'm giving you the 30,000-foot view. We're working now here at WVU for naloxone, automatic naloxone prescribing at certain levels of morphine equivalent doses. That's controversial even within our own group here of however many 800 or 900 doctors we have. But it simply relates to patient safety. And I think it's as important for children, grandchildren, and even pets in a house where there are opioids available. Next, please. This is what should be in your narcotic contracts. Next, please. This you've seen many times, DVPRS. I had a wonderful example of the use of the DVPRS in one of my patients. And I think if you go on, I don't know what's next, but yeah, so that's a picture of the pharmacy website. We're very fortunate that the website and the information in West Virginia is very good and pretty well maintained. It's been on the fritz for the last couple of days, but they assure us they're working on it. Back to the DVPRS, I had a patient that I've seen for years who's treated for chronic back pain with low-dose opioids and intermittent injections. And she's been doing well. And we embarked upon an update of our electronic medical record a couple of weeks ago, and she was one of the main troubleshooting technicians for this upgrade. And 3 days before this upgrade, her scores had been, her pain was about a 4, stress level maybe a 5, sleep was a 3 or 4, activity was a 3 or 4. So she's doing pretty well. She comes in 4 days before this upgrade, everything's a 10. What happened? I don't know. All of a sudden I have this terrible pain in my hip. I have no idea what's wrong. It feels like the pain that you treat in my sacroiliac joint. Can I have a shot? Sure you can. So we do an injection and she feels much better. And because of the nature of her problem, we see her the next day. She comes in the next day, everything's a 10 again. She said the shot helped, but it only lasted a couple of hours. In the meantime, we ordered an MRI. She has a huge L1-2 herniated disc. We started on Neurontin. We give her a Medrol dose pack, and we do an epidural steroid injection. And we see her the next day only because we know, number one, she has probably one of the biggest job assignments she's ever going to have. And we know, number two, that when we tell her she may not be able to do it, she's going to do it anyway. So we bring her back, and the 10s have now gone away. The pain is down to a 7. The stress is still a 10. The stress didn't go away until the new upgrade was done. And so you can see as we trend those in the charts, very nice, how she was stable, got unstable, and now we're working her back to stability. Go ahead, 2 slides. This is really why I thought this was important, because we're going to touch upon, and we have touched upon, the world we live in now. And so you really need to know everything that's going on in your area with respect to local, state, and federal. Senate Bill 273, if everything works out well, will be amended this session so that several things will occur that take some of the pressure off physicians. And it will state in there, has been drafted to say that pharmacies and pharmacists have no duty to enforce this law. So the phone calls you get now about, we don't have a narcotic contract on file, you don't have the diagnosis on your prescription, all of that, that's meant for that to go away over time. That will not do away with individuals that you have from across state lines, and it will not, to a certain degree, do away with those large retailers who have their own policies that make all of their pharmacies abide by. But if there are any other individuals who feel that they are the police of the world for opioids, it should help calm them down. That's the intent of it anyway. Next, please. Now I'm wide open. We're great on time. Any questions you might have?
Hello, Dr. Gabapentin.
Yes.
This is Dr. Paliwal. I mean, I'm heavily dependent on non-narcotic prescriptions, something like Lyrica and Gabapentin, to help my patient. One of the situation I'm facing is where the pharmacy is requesting 90-day prescription for Gabapentin. I mean, before it was a restricted substance, I used to do that for patient convenience and for their insurance formulary, insurance necessity need. But now, when my patients who are taking Gabapentin 1 or 3 capsules 3 times in a day, a 90-day supply means they will be getting almost anywhere from 300 and more capsules one time.
Oh, yeah.
I try to talk to my patient that it's a restricted substance. I can only give 1 month supply. And the pharmacy has argued that, no, you can do the 90-day supply. I'm still getting repeated requests from the pharmacy. The patient needs 90-day. So right now, it's a conundrum for me. I don't know what others feel about it.
Let me help you with that. So the only controlled substances that you cannot refill are Schedule IIs. Gabapentin and Lyrica are Schedule IVs. So you can write a month's prescription with 2 refills. That won't meet the 90-day supply rule for some pharmacy managers, but you can do that. And so if that will help you get out of this trap, then it's okay to do. So there's a huge difference. And the only reason that, first of all, Lyrica was scheduled from the outset. And the reason Lyrica was scheduled was because the FDA traded scheduling Lyrica at a Schedule IV level for more rapid review and authorizing it into the market. So the company took that deal because to not take the deal would mean longer process to getting it FDA approved and many more millions of dollars. Gabapentin is a different story. Gabapentin was scheduled because so many post-mortem blood tests showed gabapentin in the blood. And many individuals who use these medications use gabapentin to modulate the level of the psychotropic effects that they get. So that's the world we live in. But you can refill it, and you can write a prescription with refills. I agree with you. I would not, if you're giving it that much, if you're giving, 300s 3 times a day, that's 270 pills a month times 3. You're talking about 700, 800 pills in a bottle. I don't know how they would get that much medicine home, and I don't know what pharmacy would have enough medicine in stock to fill those prescriptions. So I don't know if that helps you or not, but that's the truth.
I mean, this is one of the things I personally feel that the Board of Medicine need to understand, that if they have declared something restricted, then the insurance cannot force the patient or us to have 90-day supply.
Well, the Board of Medicine didn't do it. The legislature did. And it is controlled, and it can be refilled. And I feel your pain about insurance companies. We have that trouble and many more with them. So I don't know that I can help you more than that. Anyone else? Wow. Either you're all asleep or that hit the high points.
Well, I was just curious. I mean, do you use a lot of nonsteroidals? I'm running into opposition from pharmacists, especially like in nursing home populations and that sort of thing, who don't think we should be using NSAIDs on anybody.
Well, without getting into too much trouble, I mean, I think there probably you could make a lot of money if you had a criminal justice pharmacy major. I don't know why that's gone that way, but at any rate, you know, obviously you're going to check kidney function and all that kind of stuff.
Mm-hmm.
But and so if someone is nursing home bound, particularly those that have mental status changes, you know, what else are you supposed to do? So, and so why do they have the ability to tell you that it's a bad idea when it may be the only thing that you have at your fingertips? I mean, we fight that too. We just probably don't. I won't say that. I'm not going to go there. We try our best every day to do what you do, is treat the patient as best we can. We started using Marinol because it's a legal THC. And we were warned late last year that as of January 1, Medicaid won't pay for it. We have a significant number of patients with neuropathy and other painful conditions that have responded exceptionally well in an opioid-sparing fashion, and they don't care. It costs too much. Anything else?
Yeah, Dr. Baglianti. Jennifer had a question. She said, what is the resistance to routine naloxone prescriptions? Is it just fear that folks will keep using it to revive each other and just keep using it?
I don't know that there's a lot of fear. I think it's mostly lack of knowledge. But it's pretty clear that over 50 MME, it should be offered. And we even, because of that, and some of that is legislated. So we even had, I forget what it's called, informed denial or something. In other words, we offered naloxone and we make them sign a paper that I don't want naloxone, so that if we're monitored for that or audited, that's in there. You know, I tried to, I have a young fella I treated for years and years with a bad back who adjusts his medications. When he's feeling well, he weans himself down to nothing. And when he's not doing well, he takes himself up. And I mean, and his wife's a nurse and he pays attention, and they have a young daughter. And I said, please take this, not for you, but if she gets a Duragesic patch and eats it, you know, you're going to be sad. And so they, you know, people think that because they take that people will think they're addicted or there's some other negative stigma, when in fact we're just trying to do the right thing. The other thing is, and maybe Charlie can add to this, is that they did the same thing to naloxone they did to EpiPens. It costs a boatload of cash, all right? And the company that manufactures the nasal formulation has just gouged the system. But I believe you can get it over the counter now in West Virginia. I know you can in some other states. But you should continue to offer it and document the refusal. Was this helpful?
Yes.
Okay.
Yes.
Wonderful. Yeah.
If we were going to do some other topic, what would be your next most sought after piece of information?
I'm not sure I know what all sorts of adjunctive things are out there now in terms of the implantable things, pumps, stimulators. I think I could benefit from a review of the procedural sorts of things that you guys do, and who would be appropriate referral.
Can do. The other thing that you need to know, and I know you're all at a distance, but we have initiated a program with these two young men at my sides here we call Fast Track Spine Care. So if you have someone who has a backache or a neck ache and you send us a referral for Fast Track Spine, we'll see them within 72 hours and we'll manage them. And we'll manage their whatever medication and their care, and if they need referred to a surgeon, and then as much as you want us to do, or if you want an opinion and sent back. So if that's something you're interested in, let us know. But we can certainly do interventions. All those things that you talk about might be more than 1 hour, so we may have to split it up. But I think we should do the very interventional stuff separate from the integrative stuff we do now.
Dr. Gabapentin, this is Dr. Paliwal. First of all, I would like to thank you. Like, I had a couple of my patients who went to your clinic or your colleague's clinic. It's just to know for the appropriateness of opioid therapy. And they received extensive evaluation, and that feedback was helpful. And while you asked about other topics that can be done to help, I mean, right now I'm trying to use like TENS unit, antidepressants like Cymbalta, duloxetine, or this neuropathic medication. But right now my approach is I try to convince them, give them a try. If they take it, if they show some improvement, I try to titrate the dose and try to achieve maximum pain control. But many of the time I'm not really confident in terms of are we doing it in a right way? Because when I give them the option that, okay, if you can tolerate it, you can, if it's helping you, we'll continue it. I mean, my goal is to maximize the use of that in an appropriate way that will help us in controlling their behavioral aspect also and pain, and hopefully avoiding opioid or even NSAID as much as possible.
I agree with you, and I know you all are in a difficult situation, but I'm impressed at how well you all do with, your basically your regional or geographic isolation. You all do a great job. There was an internal message, and yes, it's for acute or subacute back and neck pain.
Thanks.
Yep. Anything else?
I will put all of the topics we talked about and get those scheduled for us to discuss throughout this. So whenever anybody if there's any other topics, just email me, but I'll make sure to send them out to the hub members so we can get it all scheduled to talk about.
Yeah, I think it's probably on a yearly basis we should talk about interventions, integrative pain, and then implantable devices on the circuit. Maybe longer than a year, but certainly on a rotating basis, I think.
Okay, great. All right, any other questions, anybody?
Let me make sure that there are no pending. No, we're good. I just want to make sure there are no pending internal messages.
All righty. Well, great. And we can call it for today. Our next session is going to be on the 17th. We'd love to have a case. I think it's been a little bit since we've had a case from a participant, but we super appreciate Dr. Vaglianti bringing his cases in, and Dr. Ponte did the last one as well. So just keep that in mind. Everybody have a wonderful day.
Thank you.
Thanks.
Thanks.